Okay, this is actually going to be a pretty quick presentation on pain. You guys have seen some of this stuff before in your prior classes, so a lot of it may be review for you, but we'll go through it really quick here. Nociception. This is pain that's subjective. The patient either says there or says it's not. It's completely up to them how they're describing their pain and to the degree that it is. We're going to address the complaint. It does not have to involve any type of medication. There's other ways to take care of the pain. There are some objective signs that can be monitored though, such as blood pressure, heart rate, muscle spasms, guarding, the patient holding his or her breath, flinching, grimacing, and all of those other types of things. The actual definition of nociception, it's the process by which our neurological system communicates painful stimuli. There are two types of pain, and it's the nociceptive pain where we have the noxious stimuli traveling through our nerve tracts, and this is our normal function when we interpret pain. That's usually acute pain. But we also have neurologic or neuropathic pain, and this is nerve pain where the nerve tracts are dysfunctioning. The neuroanatomy of the processing of pain is one, we detect the painful sensation in our periphery. We do that through A delta fibers and also through C fibers. The A delta fibers, they're the ones that sense localized, short-term, sharp pain. And the C fibers sense diffuse, achy type of pain that lasts longer after an injury. Here's a quick schematic here where you have the alpha fibers and the C fibers. When the patient pokes themselves, the alpha fiber feels that prick right away, and the C fibers hang on to that pain for a little bit longer while the finger feels kind of achy and sensitive. Our pathways, we have peripheral. You get your painful stimulation that occurs like that poke on the finger. The tissue gets injured and releases a variety of neurotransmitters. Those in primary order neurons take the pain signal to the posterior nerve roots of the dorsal horn in the spinal cord. So those are where we have our sensory afferent nerve fibers that are receiving that information. And then it goes on to our central system where our primary nociceptor synapses onto the secondary ones in the substantia gelatinosa. The secondary nociceptors in the spine, this is where the pain gate, as it's called, is. And right here, three things can happen. The pain signal just goes right on through unchanged, or it is attenuated, and this can happen with opiates and other types of interventions, or it can actually be amplified in a dysfunctional state. The signal then ascends the anterolateral spinal thalamic tract and synapses onto the tertiary nociceptors in the brainstem and the thalamus. The tertiary nociceptors bring the pain signal to a higher cortical area in the brain, and this signal then is processed and the sensation is felt. It's pretty amazing when it's broken down this way that it seems so complicated, and we know how fast that actually happens. Neuropathic pain, on the other hand, this is an abnormal processing of pain. This type of pain is very difficult to assess and even harder to treat. It's perceived long after the site of an injury heals. Electromyography and nerve conduction studies, they're done, but they still don't give any type of definitive answer in a lot of cases. A proposed mechanism is that the injury to the peripheral neurons actually results in a spontaneous and repetitive firing of those nerve fibers, so almost like a seizure activity in the nerves. The sources of our pain, we can have abnormal nerve tracts. The pain can stem from a direct injury to an organ or from stretching of an organ from a tumor. Generally, once you have pain from cancer, it's very late stage. Cancer doesn't generally hurt until it starts affecting other things like stretching of the organ. We can have pain from ischemia, distension, or severe contraction. Pain impulses are transmitted in the autonomic nervous system, the same system that's involved with nausea, vomiting, pallor, sweating, which is diaphoresis. So that's why you'll see people in a lot of pain end up with these symptoms as well. Visceral pain, this originates from the larger interior organs. You see a list there of different things. One of the ones we've talked about most recently is a abdominal aortic aneurysm. Blood is super painful to our visceral tissue, so that will give you some extreme visceral pain. Deep somatic pain comes from sources such as blood vessels, joints, tendons, muscles, and bone. This injury may result from pressure, trauma, or ischemia. You get those pressure ulcers. The cutaneous pain, this is derived from skin surfaces and subcutaneous tissues. The injury is generally superficial with a sharp burning sensation. Referred pain, this is felt at a particular site but originates from another location, and we talked about this in the abdominal presentation. So both sites are innervated by the same spinal nerve, so it's difficult for the brain to differentiate the point of origin. And the referred pain can originate from visceral or somatic structures. So we have this picture here that we had in your abdominal lecture as well, where you can see the different sites for referred pain. Acute pain versus chronic pain. Acute, just as the name is defined, it's short-term and self-limiting, so it doesn't last a very long time. It's pretty predictable with a trajectory such as a headache or a broken bone, so it dissipates after the injury heals. The acute pain is really there to be self-protective. You go to put your hand in a fire, it hurts, you pull your hand away. So the acute pain really has a purpose. Chronic pain, this is when we've got pain going on for longer than 6 months, and it's divided into malignant and non-malignant, or malignant being cancer-related pain and the non-malignant being processes that are not associated with cancer. When we do our pain assessment, we're going to use an acronym called OLD CARTS. And it's going to go through onset, when did the pain start, what is the location of the pain, how long has it been going on, can you describe it, is it sharp, burning, dull, stabbing? What are our aggravating and alleviating factors, what makes it better, what makes it worse, does it radiate anywhere? And then timing and treatment, what caused you to come in today? Did it start today? If it started yesterday, why is today the day that you decided to come in? What treatments have you been prescribed or even tried at home? And then on a scale of 1 to 10, can you quantify the pain? So pain is this unpleasant sensory and emotional experience. It's physical and it is emotional and psychological. It's associated with actual or potential tissue damage or described in terms of such damage. It's always subjective. It's what the patient says it is. And this is the most reliable indicator of pain. So our subjective data, usually our objective data is what we really look at with patients when, in certain situations, but with pain, this is our subjective report that we really want to pay attention to. Because it occurs on a neurochemical level, you can't really decide. You can look at a patient and say, well, they don't look like they're in pain, but it is what the patient says that it is, despite any lack of physical examination. Nociception definitions, these you need to know. Tolerance, this is a diminished response to the drug. Dependence, this is a physical adaptation of the presence of a drug, and if you discontinue it, the patient will go through withdrawal. Addiction, on the other hand, this is a neurobiological disease in which a person compulsively uses a drug for purposes other than what the drug was intended to do. So pain medications, Norcos, things like that, people will use them for that purpose, benzodiazepines, but people can become dependent, but that doesn't necessarily correlate. So dependence is not correlated to addiction. They are two different and separate terms. Pain threshold is the minimum intensity at which a stimulus is perceived as pain. Hyperalgesia is an increased pain response to a noxious stimulus. Allodynia is pain response to a non-noxious stimulus. So somebody touches the patient with a soft object and they feel intense pain from that. Central sensitization. This is when you have first order neurons that are normal, but the second or third are abnormal. So this is increased excitability and then the lowered pain threshold due to that. Whereas peripheral sensitization, this is the first order neurons that are abnormal, and this leads to a lower pain threshold as well. In our pediatric population, our infants feel pain just the same as we do. Repetitive and poorly controlled pain in infants and children can result in neurological or psychological problems, poor weight gain, learning disabilities, and even substance abuse. Our elderly patients, there's no evidence that says they have any difference in the way that they sense pain with age. It's not normal process of aging. So say, oh, I'm old and everything hurts. Well, they may have a lot of things wrong. So it's not just a general process where we feel pain for no reason. They do generally have extra fears about becoming dependent on other people, undergoing invasive procedures, taking so many medications that can alter the way that they think, and having any big financial burden due to it. So common pain-producing conditions for the elderly include these listed here. But again, it's not common for them to have pain for no reason. The reason elderly patients generally have more pain is because they have all of these conditions here which cause the pain. So we try and treat these conditions to help alleviate the pain. Somatosensory cortex is generally unaffected by Alzheimer's. However, because the limbic system is affected by it, current research is actually focusing on how a person interprets and reports the pain messages. Sensory discrimination, this is perceived in both cognitively intact and impaired adults. So just because you have somebody that can't really mentate well, it does not mean that they're not feeling pain. There are actual differences in gender. It's influenced by societal expectations from hormones and your genetic makeup. Traditionally, men tend to be more stoic and withhold their pain. Hormonal changes have a strong influence on their pain sensitivity. Women are 2 to 3 times more likely to experience migraines during their childbearing years and are more sensitive to pain during premenstrual period. They're also 6 times more likely to have fibromyalgia. There is a pain gene that exists and why some people feel more or less pain even with the same stimulus. And there are efforts right now to do some type of genetic sequencing to develop medications that are tailored to a person's gene state. Pain assessment tools are multidimensional in scope. They're encompassing physical, affective, and functional domains. First, we're going to teach the patient how to use the tool with practicing sessions to strengthen the validity and reliability of it. We're going to use large print that's appropriate for individuals with impaired vision. We're going to make sure it's in the language that they speak. And this is the most common one that you'll see. It's our scale, we'd say 0 to 10 or generally say 1 to 10. And what's great about it, this one's in English, and there are plenty in Spanish as well, but regardless of the language, you can point to the face, and the patient understands, you're asking them which one they feel like. And you can always do this with young children as well. When we do our initial pain assessment, we're going to ask all of those old CARTS questions, and we may use other pain questionnaires other than just the 1 to 10, like the McGill Pain Questionnaire. And this asks patients to rank a list of descriptors in terms of their intensity and to give an overall intensity rating of how they feel. The Brief Pain Inventory, this asks the patient to rate the pain within the past 24 hours on graduated scales. And this is respect to the impact on the areas such as mood, walking ability, and sleep. And this is what the 2 of those look like, just as a reference to you. The objective data that we're going to get, physical examination that can help you understand the process of it. We're going to consider whether this is an acute or a chronic condition. We generally gather that from our subjective data. The physical findings may not support the way that they present to you. with their complaints. We have to take that into consideration. It should not be discounted when what we perceive and what we study with them as, the actual end-all be-all, and that they're, exaggerating their pain. That does happen way too often. Patients are termed have seeking behavior for pain, which they can. Addiction is out there. But we definitely don't discount their subjective report of pain because our objective data is in contrast to it. So based on the patient's pain, we're going to make every effort to reduce or eliminate it with appropriate analgesics and non-pharmacological interventions. According to the American Pain Society, in cases which there's acute pain and it's uncertain what it is, we don't know, symptomatic treatment of pain should be given anyway. There are occasional exceptions. I've got hypotensive state here, so you have somebody, whether they're myocardial infarction, they have a really significantly decreased cardiac output, you have somebody bleeding internally. Yes, these things hurt, so you have to be very careful. We don't want to lower their blood pressure anymore. So when we don't have concerns about them decompensating, we definitely want to be able to take care of their pain. The equipment that we need, tape measure, tongue blade, proper lighting, surgical pencil, the pain scales we were just showing, and possibly a camera, and that's for an injury. Nonverbal behaviors that we're going to observe, they're influenced by a wide variety of factors that we've actually already mentioned, age, cultural and gender expectations, more of a psychosocial aspect of how pain's perceived. The behaviors that we may see are guarding, grimacing, vocalizations. They may be screaming, moaning, yelling, very agitated, maybe even angry. They're restless. They may even be still. Some people just don't move. They're very quiet. They don't even want to talk. They may be sweating, and you may see a change in vital signs. With chronic pain, it's a little bit different because people adapt over time. So they may not be profusely sweating or rocking, writhing or screaming. So we can't just look for the same type of reaction as we do for acute pain. Their behaviors have even more variability though. And people with chronic pain typically try to give a little indication that they're in pain, and therefore they're at greater risk for underdetection. And this is because they don't want to be labeled as a drug seeker. Behaviors that's been associated with chronic pain include bracing, rubbing, diminished activity, sighing, and a change of appetite. So these are all kind of quiet, trying not to draw attention to them. Sleeping can be one way a person behaves in response to chronic pain. So if you go by your patient's room and you see that they're sleeping in there, don't be like, okay, well, I don't need to go in and ask them, how they're doing, because it may be completely inaccurate to think that they're comfortable. So how are we going to treat these patients, whether it's acute pain or chronic pain? It's important for you to know that drugs are not the only treatment that a nurse can provide. Definitely a nurse needs an order before they can provide it anyway. But while you're waiting for that order, you can try positioning your patient, hot, cold packs, and put them in a quiet, dark environment, especially if they've got something like a headache, and give emotional and psychological support. A lot of times having the family present, negative emotional and psychological issues can really exacerbate physical pain. And that's it.